We can hear you clear.
Thank you very much, Professor Famuyiwa. You've been a role model for all of us. Moving stuff when we were at old UCH, you were our senior and a fountain of knowledge. And many of us patterned our futures after you when we chose endocrinology. Time will not permit me to dwell extensively and fully about the impact you and our senior colleagues have had in our career choices and our dogged determination not to disappoint the motherland in diaspora. So thank you again, Professor Babatokwe, and all of the colleagues who helped put this together. I appreciate the enthusiasm for keeping endocrine knowledge alive despite the current challenges. Okay, so I was last with the endocrine group in Nigeria. Wow, 2002, that's nearly 20 years ago. And I believe that ASEN is a spin-off or somehow related to INSEM, which was the old name it was. Since then, I've been back home repeatedly to share knowledge and shake hands and hang out with colleagues in the context of not just giving back to the motherland, but also visiting family and friends. Diabetes, as you all know, was once considered rare by colonial writers, but little did they know that in the coming decades, Africa would be projected to have the largest increase in diabetes cases. And so no one, again, is hiding under the rock saying diabetes is rare in Africa. We have the disease. And in the period of years I was serving in Nigeria as a doctor, in Port Harcourt, we documented a number of lesions with Nigerian patients with diabetes. And one finding that sticks in my memory is the observation we made about the dominant role of lower extremity foot ulcers and gangrene in contributing to mortality among our patients. I hope the situation has improved. So when you look at type 2 diabetes, which explains 90 to 95% of the diabetes burden globally, you have the traditional risk factors that all of you are familiar with, the genetic predisposition, obesity, getting older, etc. But there are emerging risk factors related to the modern environmental experiences, air quality, carbon monoxide level, use of plastics and endocrine disrupting chemicals, urbanization, urban drift, socioeconomic factors, the gut flora, and now contributing to this metabolic and dysbiosis. Use of antibiotics have been associated with increased risk for diabetes. In some databases, 2 to 3-fold increased risk after 5 cycles of antibiotic exposure, presumably by altering gut flora. The intrauterine program in itself is an emerging area, fetal life, predicting adult cardiometabolic disorders. HIV/AIDS and treatment thereof is now a well-recognized factor in diabetes causality. Sleep and sleep disorders, mental illnesses, depression, stress are all contributing, but nothing prepared us for what we observed in the past year or so, that COVID-19 would be associated with increased susceptibility, increased severity, and even mortality when in people with diabetes compared with those without diabetes. So in the remaining minutes of my talk, I'll quickly touch upon the relationship between COVID-19 and diabetes, moving from clinical observations to mechanistic insights, and then specifically show data relating blood glucose levels directly with clinical outcomes, and then begging the question, the corollary as to whether improvement in glycemic control does alter COVID-19 outcomes clinically. And finally, summarize the management approaches and challenges inherent in the home environment. So this is a world map, and you see COVID, actually this is outdated when you look at what is happening in India and Southeast Asia. The hotspot is moving there. So there is no escape from this virus. It's truly a pandemic. And one of the early data from Wuhan really blew us away. When they looked at the mortality predictors, certain pre-existing conditions immediately jumped out, and those included cardiovascular disease, diabetes, chronic respiratory disorders, hypertension, cancer, and others. And if you look at this slide, you see diabetes, hypertension, really a problem back home. And then cardiovascular disease, at least cardiomyopathy and non-coronary illnesses, even coronary disease is increasing back home. So our patients back in Nigeria and sub-Saharan Africa harbor many of these pre-existing conditions that predict worse outcomes. And the prediction of poorer outcomes in hospitalized patients with COVID-19, you can see that cardiovascular disease, again, these are evidence-based data from large databases. Coronary heart disease mortality, if you look at the point estimate in this meta-analysis, it's a twofold. Look at the diamond-shaped bottom one with an I-squared of 62.3, which is moderate heterogeneity. So these are very solid data from several studies in several countries, Italy and many parts of Europe and then Asia. Then if you look at CVD, again, it's about 1.5%, 1.45-fold increased risk. Now, looking at obesity and diabetes, obesity separately, you see again, nearly 1.7 increased mortality, and diabetes is, again, the point estimate is 1.5. So consistently across various studies, the meta-analytic data give a cohesive, homogenized risk factor that is significantly higher than 50% for mortality, and then about twofold or higher for hospitalization risk and risk of requiring ventilatory intervention if people have diabetes, and even somewhat more so if they had just obesity without diabetes. So the coronary virus is an envelope virus, and in most immunocompetent individuals, it leads to trivial upper respiratory symptoms, snuffles that go away. But two highly pathogenic COVID viruses resulted in big outbreaks in 2003, SARS-CoV in Guangdong province in China. And then 10 years later, the MERS, Middle East variant came up. Then in December 2019, the Wuhan outbreak occurred, which has mushroomed into the global pandemic. And the clinical features of this disease include early middle-aged predilection, average incubation period of 5 days from exposure to symptoms. 98% of individuals exposed will develop symptoms within about 12 days. And there is a large cohort of asymptomatic carriers. However, anosmia and dysgeusia, alterations in smell and taste functions are early features, as are other manifestations such as GI, diarrhea, vomiting, and of course the severe life-threatening pulmonary consequences. Transmission is person to person by respiratory expectorations. So the genetic sequence for SARS-CoV-2 is 80%, more than 80% homologous with SARS-CoV, the earlier variants, and the Middle East variant is about 50% homologous. There is a spike proteins that have been the target for vaccine development, and you have angiotensin converting enzyme 2H2 receptor on the cell surface that mediates entry and internalization of the virus. And the expression of H2 is protean or ubiquitous. You have it in alveolar epithelial cells, on myocardium, and endothelial cells, kidney, enterocytes, pancreas. And after binding to its receptor, proteases, particularly TMP, PRES2, and furin, cleave the spike protein at the S1, S2 domain, allowing for fusion of virus to the cell surface and ultimate internalizations. Once intracellular, the variants are released and taken up into endosomes for further processing and massive and escalating replication. So in the cytosol, the replication leads to formation of mature virions that continue to spread systemically. Now, there is early lymphopenia and lymphocytopenia, the severity of which parallels the severity of COVID infection. Now, low T cell function relieves the inhibition of the immune system that leads to the so-called cytokine storm, and the specific cytokines that circulate in the blood have been identified: interleukin-6, tumor necrosis factor alpha, and CXC and CC chemokines. These are all circulating in multifold higher concentrations. And the storm is linked to some of the clinical manifestations of hyperinflammation and multi-system organ failure. The ACE is very familiar to endocrinologists, the enzyme, since it catalyzes angiotensin 1 to angiotensin 2, and then H2 converts the angiotensin 2 peptide and the Ang1 to 7. Now, these are compensatory mechanisms. So whereas angiotensin 2 induces vasoconstriction, angiotensin 1 to 7, the product of H2, the receptor for the SARS-CoV, actually mediates vasodilation and suppresses cell growth. Well, when COVID-19 binds to H2, it does downregulate the cellular expression of the H2 enzyme, which leads to unopposed action of angiotensin 2, contributing to not just vasoconstriction, but pro-inflammation, cell growth, lung injury, etc. So the downregulation of H2 is a critical mediator to the downstream toxic effects of the infection. So potential interactions with the medications that alter H2 expression must be noted. And people started opining early that since H2 expression is somewhat altered by medications we use, such as ACE inhibitors and ARBs, would we be inadvertently impacting susceptibility to the virus? I will address that subsequently, but note that some other diabetes drugs, such as GLP-1 agonists, also increase H2 expression, and insulin has repeatedly been shown to decrease H2 expression. So the American College of Cardiology and American Heart Association, as well as the Society for Hypertension, knowing that people will be concerned with the widely used ACE inhibitors and the connection, inadvertent connection through H2 to the virus, that people might be doing cafeteria a la carte medication modifications, they came up with very stout and pronounced statement that there is insufficient evidence of risk or benefit in using ACE inhibitors and ARBs in people with COVID infection. Therefore, patients must continue such treatment as required to maintain antihypertensive control. So people should not really be panicking and disrupting established and effective therapy for blood pressure, regardless of the ACE inhibitor status. So we now know that older age, male gender, diabetes, hypertension, severe obesity, and pre-existing heart, lung disease, and kidney disease increase the mortality and morbidity from COVID-19. We also now know that plasma glucose levels, independent of other factors, predict increased mortality and morbidity with SARS. So what are some of the mechanisms that may explain this? So we now know that high affinity of cell binding and efficiency of the virus entry occurs in people with diabetes. There is impaired immune function even in the ordinary case of diabetes, whereas which leads to decreased viral clearance. There is some diminution in T cell function, and the multiple risk factors of pre-existing obesity, hypertension, CVD, and kidney disease all would escalate the risk burden in the diabetic patient. And the factual observations also support that, in that there is increased H2 expression in the lungs in people with, in rat models of diabetes and in type 2 diabetic patients. The delayed clearance of the SARS-CoV-2 has been demonstrated in at least one clinical trial, and Mendelian randomization studies have identified diabetes as being causally linked to the H2 gene expression. So the mechanisms are clear, and diabetes is a slightly immunoparetic condition that now permits of escalation in the COVID risk, not just the primary infection, but sequelae such as fatalities. And this is a cartoon that kind of summarizes some of these pathways, the pneumonia, and the cytokine storm, leading to the dendritic cell surface exposure, which is a vicious circle with impaired macrophage activity and stage organ failure. What about DPP4 and the COVID status? The DPP4 enzyme is a target of several diabetes drugs that have now been approved for diabetes control. And in some studies, DPP4 was identified as a receptor for MERS, the Middle Eastern variant of COVID. And so people, by implication, thinking that it might be important in the current COVID disease, since Middle Eastern virus shares 50 to 80% homology with COVID-19. We don't know whether the same mechanisms apply to COVID-19. And we also do not know whether DPP4 inhibitors alter the cause of COVID-19. Theoretically, if the mechanisms seen in MERS translate to SARS, COVID-19, then use of these agents could reduce DPP4 concentrations and impact the cause of COVID-19. ADA and other authorities do not recommend changing drugs, including DPP4 inhibitors, based on some of these theoretical concepts. So the question as to whether blood glucose control affects outcomes has been definitively answered for us. In a cohort of more than 7,000 COVID-19 patients with or without diabetes that were studied retrospectively, diabetes status increased the need for medical interventions, including respiratory support, and diabetes status increased mortality risk. However, well-controlled diabetes during the course of inpatient treatment correlated with improved outcomes. Hemoglobin A1C per se did not predict this, suggesting that it is acute hyperglycemia rather than chronic stable dysglycemia that is being linked to the COVID-related morbidities and mortalities. So this is a Kaplan-Meier plots of survival on the basis of diabetes status, normoglycemia in green, which is the longest survivors, then diabetes status in the middle group, and then in-hospital hyperglycemia, the worst survivors, as you can see. And then glucose control while in hospital is associated with survival, and you can see flattening of the curve in multiple studies, including mortality outcomes. So that is reassuring. And then new onset diabetes during COVID infection in people who previously not known to have diabetes, that is also a problem. And now the risk of that, likelihood of that is probably 10 to 15%. And so in many studies from China through Europe, we're seeing that people who did not have diabetes before, upon infection by COVID, can develop new onset diabetes. Mechanisms, again, are related to stress response, as well as use of glucocorticoid and potentially other several convoluted mechanisms, which I summarized here for you. So the challenges facing physicians who want to improve glycemic control in diabetic patients are huge. You have social isolation, contact protection, all kinds of gloves, wearing, and then blood draws for multiple measurements of glucose. All of those are challenging. Then the medication choices themselves are guideline directed based initially on a broad long-term benefits of cardiovascular risk reduction. As many of you know, ADA, ACE, and many guidelines are predicated upon the drug's impact on cardiovascular risk reduction, because the vast majority of patients with type 2 diabetes die from CVD. That has been superimposed upon the COVID-19 considerations. So we don't have a lot of organizations scrambling to bring new guidelines, but key opinion leaders, including my former mentor, George Alberti at Newcastle University, now in London, David Hopkins and many others got together, as well as some US-based people, including Jay Schuyler and the current ADA president who took over from me, Bob Burkle. They got together and said that at outpatient level, in the approach to patients with diabetes and COVID, we should stress the importance of optimal glycemic control, and then take steps to improve the control using any agents that is available and tolerated. And in inpatient level, we should monitor for new onset diabetes, given the known risk of the stress of infection for triggering hyperglycemia. And then people in the ICU who have been treated, we should again intervene very closely. But what do we use to control the glucose? And the consensus preference is insulin for the critically ill individuals. And the goals are glucose levels of 4 to 8 millimoles, about 72 to 144 milligrams per deciliter for those in the US. Up to 180 may be tolerated, but you don't want glucose running much high in that range. A1C should be 7%, but that is irrelevant in the acute hospital setting. Continuous glucose monitoring has become very useful in our center for frequently monitoring the glucose levels and the ranges. Again, about 70 to 140 range, we try to keep people. We avoid hypoglycemia because that spells ill for the patient's outcome. And the goal should be have less than 4% readings showing values of below 3.9. So with regard to the drugs to use, there are several options. Metformin is associated with lactic acidosis in ill patients, so we want the drug to be stopped. The recommendation to discontinue metformin during COVID illness, especially the severely ill people. SGLT2 inhibitors are associated with glycosuria and risk of dehydration and DKA in some people. So again, recommendation is to discontinue. So we lost two great drugs. GLP-1 receptor agonists, mostly injected, but semaglutide oral is available. Dehydration risk exists, so patients should be monitored closely, but it can be used. DPP-4 inhibitors, despite what I said about theoretical receptor-mediated interactions with COVID, again, they are well tolerated and can be continued. Insulin is the nuclear weapon we use for COVID-infected diabetic patients. It's always appropriate, always well tolerated, can be adjusted to reach goal, but anticipate insulin resistance-induced high insulin requirements. We're seeing patients with double digits per unit per kg insulin requirements. So don't hesitate to crank up the insulin dose when the glucose is not budging. And we use tele-endocrinology at my center to separate ourselves from the infected patients. And many centers are using one form or the other of telemedicine. Comorbid conditions, blood pressure, especially should be controlled. Blood glucose controlled with statins. Statins, by the way, increase the H2 receptor, which in the infected patient is thought to mediate vasodilation and prevent clots, so which is kind of good. For Africa and our countries, we have problems despite all of the well laid out roadmaps. We don't manufacture diabetes drugs locally. Insulin is largely imported at prohibitive costs. Lab support is often spotty at best. And whilst we have great experts on this forum, but the expertise is not well distributed across rural areas, so pockets of the country may lack people with the technical know-how to manage diabetes effectively, and telehealth is challenged by connectivity issues. And I heard a talk about insulin, modern recombinant insulin, but keep in mind that those are probably beyond the reach of many of our patients, and there is nothing wrong with regular human insulin or even beef pork insulin if you must use those, but human insulin is now widely available. And the affordability of drugs for diabetes treatment across the world remains a major moral issue. And this graph shows the country by country, high income countries, and then upper, middle, low income countries, and metformin availability all the way to insulin availability being very low. And when you look at the affordability, the household capacity to pay, here, the higher the bar, the worse the data. In other words, you have a function, household dollar disposable income as a function of the cost of the drug. And again, in low-income countries, we are spending far too much of our household income on insulin provision. So the lower the cost of the insulin, the better it should be for our patients. WHO also has suggested that we give sulfonylurea and inexpensive medication that can control the diabetes, and we not necessarily default or devolve to expensive recombinant fancy designer drugs if older drugs can do the trick. So we recently published an article in the Niger Delta Medical Journal upon request by the editor titled Management of Diabetes in Environments with Limited Resources. It's publicly available online. I recommend you pull and peruse it, but there we recommended use of local adapted dietary approaches, negotiating the frequency of monitoring with patients based on their ability to afford instead of robotically following, say, ADA guidelines to get A1C every 2 to 3 months when patients can afford it. The medications themselves using generics whenever possible, free supplies, unabashed begging for the companies to drop off supplies is part of patient support program, and research. Whenever clinical research, I was quite quite pleased to hear about the trials that were being reported by Dr. Chineye and others. So clinical trials allow us to offer medications and clinical care to patients at no cost, sometimes with even some reimbursement. So I conclude by, again, reminding you of what you do know, that there is an unholy alliance between COVID-19 and diabetes that translates to increased susceptibility, increased severity, and poorer outcomes in terms of mortality. Whilst the underlying mechanisms are still being unraveled, we do know that cytokine storm does play a role, and the pre-existing diabetic milieu is a favorable one for COVID to become established. However, it is very nice to know that optimization of blood glucose control acutely can improve outcomes, and that becomes the compelling approach to our patients. We need adaptations to the routine diabetes care in pandemic times that require social distancing, remote patient monitoring, use of wearable technologies. And in terms of drugs, insulin is probably the safest harbor if it's available. And challenges that occur in the low and middle income countries require innovative approaches during these COVID times. I encourage every hospital, every caregiving environment to start, if they have not already done so, a COVID-19 patient registry, and then include outcome data and diabetes status. And finally, whenever the vaccine becomes available, I beg you to prioritize vaccination for your diabetic patients. I will stop here and again thank the organizers for putting together such an outstanding conference.